Greetings, everybody, and welcome to part 22 of our internal medicine review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the costs of these videos. $1 a month goes a long way. Everything gets put into the technology and the research material that I use to put these videos together. So I thank all those of you who have already donated, and definitely if you're a medical student, I understand why you can't donate. I was a poor medical student at one time myself. You may hear some barking in the background. This is Thor. He is my new German Shepherd puppy I got in November. I used to have a German Shepherd. His name was Axel. I got him in 2011 when I was just finishing up med school. And he passed away a couple years ago. He was 11 years old, which is a respectable lifespan for a German Shepherd. They typically live 10 to 12 years. So took a while to get my heart back together to get another German Shepherd, another dog, but it's worth it. I don't know if 10 years, though, it's going to be another struggle, but it's amazing how much that can affect you. All right, let's go ahead and do question 1. Now, this is going to be 3 questions, so you're going to put in your answer here, and then we're going to move on, and we're going to do 3 questions. We'll come back and review each one. So question 1, a 35-year-old woman presents to the clinic after learning one of her male sexual partners tested positive for HIV. She has also had intermittent headaches, nausea, and blurry vision over the past couple weeks. She denies fever, sore throat, and rashes. She has no chronic medical issues. Medications include levonorgestrel IUD and a multivitamin. She is sexually active with multiple men, and they use condoms most of the time. Vitals are within normal limits. On physical exam, there is generalized lymphadenopathy. The remainder of the examination is normal. Labs show an HIV 1-2 assay that is positive. Serum HIV RNA is 2.2 million units. CD4 count is 275. RPR plasma, I should say reagent. My spell check fixed that for me, but it is reagent, not regain, is 1 to 128. FTA-ABS is positive. CT of the head is unremarkable. Which of the following is the best next step in the management of this patient's positive FTA-ABS lab? A, repeat serologic testing for syphilis after antiretroviral treatment is started. B, perform lumbar puncture to obtain CSF for VDRL testing. C, administer intramuscular benzathine penicillin G. D, administer IV ceftriaxone. Or E, no further testing. This is likely a false positive test. Okay, so we're going to move on to question 2. So you can pause, pick your answer. We're going to move on. Additional tests are normal. Which of the following is the most appropriate medical therapy for this patient? A, IM benzathine penicillin G 2.4 million units once. B, IM benzathine penicillin G 2.4 million units weekly for 3 weeks. C, IV aqueous crystalline penicillin G 4 million units every 4 hours for 3 weeks. D, PO doxycycline 100 milligrams twice daily for 2 weeks. Or E, IM ceftriaxone 1 gram daily for 2 weeks. Okay, so I know what you're thinking, but I don't need to know doses for the steps. And that is true with the exception of this. And maybe a couple others, but this one in particular. Okay, we're going to move on to question 3. We'll talk about dosages. Appropriate treatment is started. The following day, the patient calls your office complaining of flu-like symptoms. Which of the following could have prevented this reaction? A, concomitant treatment with hydroxyzine. B, concomitant treatment with diphenhydramine. C, concomitant treatment with prednisone. D, assessment of a patient's allergies. Or E, no prevention is available for this patient's reaction. All right, so you go ahead and lock in your answer. And we're going to talk now about question 1. So the answer to question 1 was a lumbar puncture to get VDRL testing. So what is going on with this patient? So she is coming in because she thinks she was exposed to HIV. She's got headaches, nausea, blurry vision. Well, headaches and nausea, that could be possibly an acute HIV infection. Acute HIV infection has a lot of flu-like symptoms involved. So maybe it's that. But the blurry vision is unusual. That typically would not come from an acute HIV infection. So we don't really know what's behind that. She doesn't have fever, sore throat, and rashes, and we would tend to see that in an acute HIV infection. So we don't really know what to make of that. Remember, always, 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 when you're approaching test questions, look at the last part of the question so that you know what you're going to be thinking of, how your brain is going to start rolling when you go through these questions. We know that she is highly sexually active, doesn't always use protection. There's lymphadenopathy, and we know that she is HIV positive. She's got a positive viral load. Her CD4 count is low. It's 275. So she definitely has HIV. But then when we go and do all these other STD tests, which you should do when you have a patient who's positive for HIV, you want to test them for the whole gamut of STIs. What we then find is a positive RPR. Okay, that is our screening test. So now we do the FTA-ABS. That comes back positive. Boom, diagnosis of syphilis. Now the question is, what syphilis is it? Is it primary, secondary, latent, or tertiary? However, this question is asking, what do we do about this syphilis? So I know the most common wrong answer here was probably C, to give benzathine penicillin G to treat the syphilis. However, we don't know what stage of syphilis this is. It is probably latent, but we don't know. And the reason we don't know is because she has neurologic symptoms. And anytime you have a patient with diagnosed syphilis and neurologic signs, you must get a CSF. It is as simple as that. Repeat serologic testing for syphilis, no need to do it. This is a positive diagnosis. Yes, we will put her on antiretroviral treatment, and we will send her off with a script after this visit. Okay, go off with Biktarvy, but not now. IV ceftriaxone, no. That is an alternate therapy for some stages of syphilis. No further testing. False positive. Okay, so you can get false positive plasma reagents, the RPR. However, that is unlikely in this patient because she has a positive confirmatory test. So remember, things like lupus, a recent mono infection, being on certain drugs like antiarrhythmics, those can all cause a false positive test. Okay, but unlikely in this patient. There's nothing in her history that indicates a risk factor for a false positive test. So here are your manifestations of syphilis. We're not going to run through all these, but primary, secondary, latent, and tertiary. This patient is probably latent, but we don't know. She could have neurosyphilis. We have to make sure and find out. There are two flavors of latent, early latent and late latent. What's the difference? Early latent means they were exposed less than a year ago. So if they said, yeah, I had this wart or whatever they want to call it, this ulcer on my penis or on my vulva, and it was 6 months ago, then we can safely assume that this is early latent syphilis. But if they said it was 3 years ago, then because that's more than a year, we call it late latent. And actually, this is the cutoff. This is where we change the treatment, which we'll talk about in a little bit. However, in this patient, she doesn't know when she was exposed, or at least the test question doesn't tell us. So we treat this as late latent, but what we call it is unknown duration. We'll call it latency of unknown duration. We treat it like late. Okay, so remember that. You don't need to guess. If they don't tell you a time frame, you just go with unknown duration. You'll treat it like late. Tertiary, that's your neurosyphilis. Cardiovascular, the spirochetes can get inside the wall of the aorta, weaken it, and cause a dilation. And then you can also get the gummas. Here are the diagnostics. We talked about these. Remember, with the non-treponema, you can get a false positive if it's very early on. So if they told you I was exposed to syphilis a week ago, you may want to just get a treponemal test, and that will tell you it's got better sensitivity in early infection. The nice thing about the non-treponemal is that it will go away because, complex reasons, but because it can go down, because it's quantitative, you can use it to monitor response to treatment. Okay, so there you go. Okay, now question 2 was intramuscular benzathine penicillin 2.4 weekly for 3 weeks. Why? Okay, so all of these are potential answers for treatment of syphilis. 2.4 million units once. That is for primary, so they have the chancre. That is for secondary, so they have the rash. And for early, latent. So that means they don't have symptoms, but they know, I had sex for the first time 6 months ago. Well, then you know that was when they were exposed. Or I had the chancre 8 months ago, or I had the chancre 3 months ago. That is early latent, less than a year. Weekly for 3 weeks, this is going to be for late latent and tertiary, except neurosyphilis. If it is neurosyphilis, then we must do IV aqueous crystalline penicillin G 4 million units every 4 hours for 3 weeks. So much more frequent dosing. That is neurosyphilis. This patient didn't have neurosyphilis. The additional tests were normal. So now she is what? Latent of unknown. And I didn't write it here, but that's right here. Latent of unknown is B. Weekly for 3 weeks. We treat it like latent. P-odoxycycline, that would be done as an alternative treatment for late latent or unknown duration. If the patient has an anaphylactic reaction to penicillin, we can do that. However, we would not do it, obviously, in children, but children typically do not have syphilis. IM ceftriaxone, that would be an alternative treatment for tertiary syphilis, with the exception of neurosyphilis, because neurosyphilis must always be treated with penicillin. Why? Because it's got really good CSF penetration. Now, what if they tell you that the patient has neurosyphilis and they have anaphylaxis to penicillin? You're screwed, right? No, you're not. You can actually do a desensitization to penicillin and then treat them with the penicillin, okay? But that's the only time you'll have to do that. If they've got primary syphilis and an anaphylactic reaction to penicillin, you can do a doxycycline, okay? So you don't have to use penicillin. You only have to use penicillin in neurosyphilis. So here you go. This is everything we talked about. All right, now question 3 is no prevention is available for this patient's reaction. Why? What is this reaction? So you've got syphilis, you start penicillin, and then like within hours you develop flu-like symptoms. This is the Herxheimer reaction, famous. Okay, so basically what's going on here is that you're giving the penicillin, there's rapid lysis of the spirochetes, they release their proteins, that causes an innate immune response, release of cytokines, we're talking TNF, IL-6, IL-8, and that triggers flu-like symptoms. And that's exactly what this is. It's flu-like symptoms. All right? Now, what can we do about it? What could we do to prevent it? Nothing. There's nothing you can do to prevent this. And that's okay, because it only lasts a few days, and what you can then do is you can do symptomatic care. So you can give them antipyretics for a fever. If they've got body aches, you can give them NSAIDs. You treat it symptomatically, it goes away fast. Most of the time, patients are just going to be kind of freaked out about this because you give them medicine and now they're sick. So something you'll want to reassure patients about. So this is the Herxheimer reaction. We talked about this. It can also occur in the treatment of other spirochete disorders like Lyme, or maybe you're not going to see this as much in the U.S., but leptospirosis. So there's a number of spirochete infections where this can happen. All right. Okay, let's move on to our next patient. We got a 42-year-old woman presenting to the clinic complaining of intermittent abdominal pain for the past 6 months. She's worried she's got cancer as her father died of pancreatic cancer 2 years ago. She says she doesn't know what triggers the episodes, but they last about half an hour and are worsened with breathing. The pain is described as dull, plus 4 out of 10, and radiates to the right shoulder. She has no significant past medical history. She doesn't smoke, drink alcohol, or use drugs. BMI is 30. Vitals are within normal limits. Physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A, CT abdomen, B, abdominal x-ray, C, right upper quadrant ultrasound, D, H. pylori stool antigen, or E, serum amylase and lipase. So this, we're going to go on to question 5. You need to lock your answer here. We got 2 more follow-up questions. Okay. Ultrasound is performed and reveals multiple stones in the gallbladder lumen. No distension or thickening of the gallbladder wall. Cystic duct and common bile duct are normal in diameter and no masses are visible. BMP and LFTs are within normal limits. Which of the following is the best next step in the management of this patient? A. Endoscopic retrograde cholangiopancreatography, or ERCP. B. Hepatobiliary amino-diacetic acid scan, or HIDA scan. C. Prescribe ursodeoxycholic acid and advise weight loss program. D. Elective cholecystectomy. Or E. No further management is needed at this time. Okay, I'm going to move on to the next one. It's the last one for this little set here. After declining recommended therapy, the patient returns 2 months later. She now complains of severe abdominal pain over the past 24 hours. The pain is described as coming and going and is rated as 6 to 8 out of 10. She has also had 2 episodes of emesis since the pain began. Vitals are given to you here. On physical exam, there is mild scleral icterus, exquisite pain at the right upper quadrant, and no rebound or guarding. Labs are as follows. Abdominal ultrasound reveals a mildly distended gallbladder with multiple stones, no pericholecystic fluid, and dilation of the common bile duct. There is dilation, okay? Which of the following is the best next step in the management of this patient? A. CT abdomen. B. Immediate cholecystectomy. C. Endoscopic retrograde cholangiopancreatography, or ERCP. Or D. A HIDA scan. Okay, so now we are going to talk about question 4. So the answer is right upper quadrant ultrasound. Let's talk about this lady. So she is 42, okay? She is a woman, and she is technically at the lower range of obese. So remember your mnemonic: fat, female, fertile, and 40s. Well, she's at least 3 of these, and she is probably all 4. So those are your risk factors for gallstones. Okay, now whether that causes symptoms or not is a question, but those are the risk factors. Now, what do we know also about this patient? Is the fact that her dad died of pancreatic cancer 2 years ago a big problem? No, her dad was probably, let's say he was 25 when she was born, so her dad was probably 65 years old, and that's a typical age to die of pancreatic cancer, to have pancreatic cancer. We're not thinking here of a familial cancer disorder. Also, pancreatic cancer is typically painless, and that's the problem. Okay, it typically doesn't present until you get jaundice, and she's got a painful jaundice. That's not how pancreatic cancer presents, so you can tell her right off the bat, this is not cancer. Okay? Now, what about the pain? What kind of pain is this? So the kind of pain that it comes on and it crescendos and then it decrescendos and you have no pain. And then maybe 10 minutes later, it comes on, it crescendos, decrescendos, and then the pain is gone. That is called colicky pain. And we see it when there is an obstruction with some kind of, we'll call it peristalsis, some kind of contraction behind it. So this is the kind of pain that you might get in a bowel blockage, or the kind of pain you might get with a kidney stone, where you've got something and then whatever's before it is trying to push against it. And that is what causes colicky pain. So you hear colicky pain that comes and goes. You got to think of an obstruction. Okay, so CT abdomen, abdominal x-ray, not good for looking for stones. We think she's got stones. Okay, we think this is either a cholecystitis or a biliary colic. H. pylori stool antigen, when would we do that? So we would do that if she had dyspepsia. This is not dyspepsia pain. Dyspepsia pain is epigastric. It does not radiate. It's often described as burning rather than dull. And if it does radiate anywhere, it may be appreciated in the back, but as far as test questions are concerned, it's burning epigastric pain that doesn't radiate. It also can cause early satiety. So it's not that. Serum amylase and lipase, when would we do that? If we thought it was pancreatitis. Okay, does this look like pancreatitis? No. First of all, pancreatitis is really, really painful. Okay, really painful. My dad had a bout about 10 years ago, and He told me it was the worst pain that he's ever had in his life, and that's saying something. So pancreatitis is also epigastric, like dyspepsia, but it's going to radiate to the back. Pancreatitis, they're going to be sick. They're going to have a fever. So also look at the history. We're talking 55-year-old man, chronic alcoholic, something like that. Then we might think pancreatitis. Not in this patient. If you had to pick between amylase and lipase, though, and you thought pancreatitis, which would you pick? One or the other? Lipase. Okay. So biliary colic, basically what happens is you have a stone, the stone gets lodged in the cystic duct, but then it eventually makes its way out. So what's happening here is that these patients will get this colicky pain, but they'll come in episodes. So it comes and goes, and then after about 4, 5, 6 hours, it's resolved, and maybe they don't have another episode for, months or even years. Okay? However, the fact that they have stones, the fact that they're symptomatic, that means we need to take the gallbladder out, okay? We have to take it out. Because what happens if one of these stones comes down here and blocks it? Then we got a big problem on hands. What if it comes down here and blocks it? Got a big problem, okay? So you need to take it out when you got biliary colic and stones. So here is what we just talked about. This is your answer here, okay? So why are we doing the cholecystectomy? Because she's got biliary colic plus documented stones. That is a one-way ticket to elective chole, usually performed laparoscopically. So it is elective. That means that it doesn't have to be done at this visit. It could. I mean, in theory, it could, but it doesn't have to be. We tell her, come back in when you're ready, and we need to take it out. Now, why do we need to take it out? Because almost a quarter of patients who have biliary colic, they will go on to need a cholecystectomy within 10 years, i.e. they will develop cholecystitis, or even worse, they could develop choledocholithiasis. And then they need to have an emergency intervention. And so we prefer that not happen. What if you can tell this patient, what if you go to Greece or you go to Japan or you go on some fun trip, you're backpacking in Peru, and then all of a sudden you get right upper quadrant pain, fever, nausea, vomiting, sweats, and all that stuff. Do you want to be on vacation when you ultimately get cholecystitis? And the answer is no. Let's get this out now and prevent a problem from happening in the future. ERCP, it visualizes the bile duct, tells you absolutely nothing about the gallbladder. HIDA scan, that tells you how the gallbladder is working, but it doesn't really tell you anything about the blockage. Now, when would we do a HIDA scan? That would be if you had biliary colic and no evidence of stones. Then we need to know, is this functional? So in that case, you would do a HIDA scan. But that's really the only time we're going to do the HIDA scan. We don't need to do it here. We have evidence of stones. We know what's causing this. Prescribe ursodeoxycholic acid and advise weight loss program. So ursodeoxycholic acid can be given to patients with biliary colic if they're poor surgical candidates. However, this patient is not a poor surgical candidate. When else do we give ursodeoxycholic acid? You got to know this, super high yield. Primary biliary cholangitis. It's the treatment of choice, so know that. No further management at this time? No. She needs the elective chole. Okay? So here's everything we talked about. It's just all on one slide. You can screenshot this and keep it. Okay, now question 6. What happened? Well, she decided, I don't want to get the cholecystectomy. I don't want surgery, I'm afraid. Okay, and then 2 months later, she comes in and now she's really sick. So now she's got worse pain. She's throwing up. She's got a fever, tachycardic. She's got scleral icterus. Her white count is elevated. Her transaminases are mildly elevated. Her ALK phos is very elevated. Her bilirubin is elevated, as we would expect with the jaundice. What is going on here? Anytime you see an elevated ALK phos, you better be thinking bile duct, common bile duct. Okay? And in fact, when we do the ultrasound, we see dilation of the common bile duct. What is this? This is choledocholithiasis. Specifically, what this means is that you have a stone in the common bile duct. I just told you, what if that happens? Oh my gosh, it did. Okay, hopefully she wasn't backpacking in Peru. So, she's got choledocholithiasis, but what else does she have that's concerning? That fever, that white count. Choledocholithiasis can cause acute cholangitis, an emergency. Okay, what do we do with acute cholangitis? Can we just take the gallbladder out? No, the problem is in the bile duct. So yeah, we are going to take the gallbladder out. I'm sure it's packed with stones that could cause problems later on, but right now, we got to get that stone out. And the only thing on this that is going to get that stone out pronto is the ERCP. CT abdomen, yeah, visualize stuff. We already know what's going on here. Cholecystectomy, she's going to get a cholecystectomy at this visit, and we're going to lay the law down and tell her she needs to get it this time. But as for now, we need to do the ERCP. And HIDA scan, again, very diagnostic. We know what's going on. Remember, the HIDA scan is for colic, but no visualized stones. Okay? And that's really the only time we're doing that HIDA scan. So here's choledocholithiasis. Remember, right upper quadrant pain plus fever plus jaundice plus altered mental status plus hypotension. What do we call that? Reynolds pentad, and that is acute cholangitis. Of course, you're going to see all the other things, the elevated white count and all that stuff. Remember with choledocholithiasis, yes, you'll have disturbed transaminases, but it's going to be the elevated ALK phos that's going to give it away, very high. Elevated bilirubin, they're often going to have jaundice. That T-bili direct fraction is going to be elevated. Best initial test on suspicion, right upper quadrant ultrasound. You see the common bile duct dilation, boom, choledocholithiasis. Next test is to get ERCP, diagnostic and therapeutic, remove the stone, and then at the same visit, they're in for a cholecystectomy. Complications, acute pancreatitis, stone gets lodged in the pancreatic duct is blocked, you get inflammation, pancreatitis. Acute cholangitis, we talked about it, you get an infection behind the stone. That's a very classic principle of pathology, okay? Out, in, blockage here, inflammation, infection there, okay? Acne, you get a blockage of your pore, causes an infection. Lots and lots and lots of things work this way, okay? All right, everybody, let's move on to question 7. We got a 62-year-old guy brought into the ED from an outpatient dialysis clinic after developing shortness of breath and wheezing. Approximately 40 minutes ago, he received a heparin flush prior to dialysis and also IV iron for iron deficiency anemia, which had been diagnosed during that visit. Past medical history is significant for type 2 diabetes and end-stage renal disease secondary to diabetic nephropathy. Vitals show blood pressure 88/63, heart rate 109, respiration 22, temperature 98.6, saturation 94% on room air. He's in mild distress. There's pale conjunctiva, flat neck veins, bilateral wheezing present. Heart sounds are muffled, tachycardic, and no murmurs. The skin is flushed. There's mild pitting edema of the lower extremities bilaterally. Which of the following is the most likely cause of this patient's presentation? A, pericardial tamponade. B, acute myocardial infarction. C, uremic pericarditis. D, anaphylaxis. Or E, pulmonary embolism. Okay. Let's move on to our answer here. The answer is D, anaphylaxis. All right, so when you are approaching test question, a lot of students think, okay, I need to see what is actually going on with the patient. What are our pertinent positives? And that's great. That's good. It's a good way to think. But that's probably not going to get you all the way. You also need to consider the pertinent negatives. What do we expect with each of these things that maybe isn't there and that we can rule things out? Have you ever met a person who's having a heart attack who doesn't have chest pain? I haven't. Myocardial infarction's out. This guy doesn't have chest pain. He's got shortness of breath and wheezing. What else would give you chest pain here? Well, pericarditis gives you chest pain, so that's out. Pulmonary embolism, yeah, you get some chest pain, pleuritic chest pain. All right, so now we're down to pericardial tamponade and anaphylaxis. So pericardial tamponade, is that going to give you bilateral wheezing? No. So there you go. You got your answer. So this can look daunting, but if you bear in mind your pertinent negatives, you can eliminate the wrong answers. Now, why is there an anaphylactic reaction? Was he given any medications? I mean, was he allergic to heparin? Probably not. What about iron? IV iron, can that cause an allergic reaction? Yeah, yes, it can. So you can have an allergic reaction to intravenous iron. So this is the answer. Now, some other things that kind of give this away, I mean, all this stuff is consistent with anaphylaxis. You've got the wheezing and the shortness of breath, that's bronchoconstriction. You've got flushed skin, that's vasodilation because of decreased resistance. So you've got dilation of vessels. That's why when people have an anaphylactic reaction, they generally turn red in the face. Pitting edema from third spacing of fluids. So, all of this stuff is very consistent with anaphylaxis. And also the hypotension, too. So this is the diagnostic criteria for anaphylaxis. If you want to memorize this, that's fine, but just have a general idea of what it looks like. So rapid symptom onset. Anaphylaxis doesn't come on over 3 or 4 hours. It comes on over 3 or 4 minutes. So rapid symptom onset. And then any one of the following. Skin or mucosa involvement. That could be as simple as hives. And then either hypotension or respiratory distress. That was this patient had hypotension, respiratory distress, and he had redness of the skin. There you go. There's your diagnosis. But he also had the wheezing, so he had respiratory symptoms, he had hypotension, so he had cardiovascular symptoms, so he meets this criteria too. And then hypotension after exposure to a known antigen, that's iron. He had hypotension, so he meets that one. So this is a very obvious case of anaphylaxis. All right, question 8. 52-year-old man presents to the ED after an episode of bloody vomiting. He is a self-confessed alcoholic and had a drinking binge last night. This morning, he woke up with symptoms of nausea, which resulted in forceful retching. Initially, the emesis was clear, but then he noticed a pink tinge in the vomitus. Past medical history is significant for type 2 diabetes and chronic alcoholism. He was admitted 3 months ago, 2 years ago, and 6 years ago for episodes of acute pancreatitis. He drinks 4 to 6 standard alcoholic beverages daily and sometimes more on the weekend. He denies tobacco and recreational drug use. Medications include metformin and a multivitamin. Vitals show blood pressure 108/77, heart rate 94, respirations 12, temperature 98.6. Physical exam is remarkable for mild splenomegaly, but is otherwise unremarkable. Labs are obtained and are as shown. I'm going to show you these labs now. Okay, so you can pause and take a look. And once we go through the answer choices, I'll bring you back here. Okay, EGD reveals several small erythematous erosions at the gastroesophageal junction. Varices are seen at the fundus of the stomach, but no esophageal varices are appreciated. Which of the following is the most likely cause of this patient's varices? A. Portal vein thrombosis. B. Splenic vein thrombosis. C. Budd-Chiari syndrome. D. Hepatic veno-occlusive disease. Or E. Polycythemia. Okay. So let's take a look at those labs again. So here you go. All right, let you look at the answers one more time. Pause it, and we're going to move on to our answer. So the answer is splenic vein thrombosis. So this requires you to know your anatomy. And if you know your anatomy, you're going to get the right answer to this one. And what you need to know, I'll show you a picture right here. It's as simple as this. Here's your splenic vein, and you need to know that when you have a blockage anywhere, all the veins downstream from the vein that's being blocked, whether that be from cirrhosis, blocking the portal vein, causing increased resistance, or a splenic vein thrombosis right here, everything downstream in terms of veins are going to be engorged and dilated. Well, it so happens that the short gastric veins drain into the splenic vein. Okay, so if you have a blockage here, a thrombosis of the splenic vein, then these short gastric veins are going to be dilated. They're going to be tortuous. They're going to be variceal. And that's, in fact, what we see here. Now, if, in fact, you had thrombosis of the portal vein or of the hepatic vein, then you're going to see downstream from that. So you would expect to see esophageal veins. You'd see esophageal varices. You may see varices even further downstream from that, maybe hemorrhoids. So in this case, though, since we only see varices at the fundus of the stomach, all you need to know is if you're at the fundus of the stomach, those are short gastric veins, those drain into the portal vein, and so it must be the portal vein. Because if it were the hepatic vein or if it were the portal vein, then we would expect to see esophageal varices as well. Okay, so it's really that simple. This is just an anatomy question disguised as a clinical vignette. So portal vein thrombosis, we talked about that. Budd-Chiari syndrome, kind of along the same lines, hepatic veno-occlusive disease. All of these things would cause esophageal varices. Polycythemia, it's a cause of thrombosis in the hepatic vein. It's one of the more common causes. Okay, question 9. A 33-year-old man presents to the ED complaining of excruciating right eye pain. He says that he was talking to his brother in his wood shop, and as the brother was using his power saw, he felt debris hit his face, and this was followed almost immediately with pain in his right eye. Since then, he's had diffuse eye watering. He has no significant past medical history. Patient is covering his right eye with his hand and is reticent to open his eye for examination. Brief exam of the right eye reveals conjunctival erythema and photophobia. Pupil is round and reactive to light. Left eye is unremarkable with normal visual acuity. After administration of a topical anesthetic, fluorescein dye is applied and multiple vertical lines of increased uptake are visual on the cornea. Which of the following is the best next step in the management of this patient? A. Gramstein culture of ocular secretions. B. Tonometry. C. Eversion of the eyelids and copious irrigation. D. Discharge with topical anesthetic and follow up in 1 week. Or E. Ophthalmology consult after patching the right eye. All right, so let's go ahead and move on to our answer here. Eversion of the eyelids and copious irrigation. What is going on here? What is this? This is a corneal abrasion due to a foreign body. Very, very common. You see this a lot. As a matter of fact, when I was really little, I was like probably 5 years old, my sister was just a baby. My sister scratched my mom's eye. And I remember I used to have this, when I was a kid, I had this little glow-in-the-dark shirt, had little like print that was glow-in-the-dark. And when the doctor turned on the woods lamp, my shirt just glowed up like a Christmas tree. So that was one of my early experiences in the clinic, not as a doctor. So anyway, so what is going on? Well, it's very obvious that there was some kind of foreign body. Debris hit his face, and it was followed almost immediately with pain in the right eye. That's telling you something struck the eye, a foreign body. There was diffuse eye watering, and it's very, very painful. Is a corneal abrasion painful? It is extremely painful to the point where sometimes we have to put patients on narcotics just so they can sleep. It is that bad, okay? However, what we don't do is we don't give topical anesthetics. Never. You virtually never discharge a patient with topical ocular anesthetics. So you just won't do that. Gramstein culture of ocular secretions? No, it's not an infection. Not an infection. This happened right away. You know it's a foreign body. Tonometry? So tonometry may be performed, but it's not the best next step. Tonometry would be a good one to do if you thought this patient had acute angle closure glaucoma. So if, for instance, he had a rock hard eye, it was very painful, maybe described almost headache-like, and there was conjunctival erythema and visual changes, decreased visual acuity. That you would expect to see a glaucoma. You would do a tonometry and look for elevated intraocular pressure. That's not going on here. Or alternatively, if we were to think maybe an open globe laceration, so if he had a pupil that looked something like that, well, then we might get tonometry looking for a decreased intraocular pressure, because if you had an open globe laceration, aqueous would flow out, and that would decrease the intraocular pressure, but that's wrong. And then ophthalmology consult after patching his right eye. That is what we do for open globe injury. So again, you would see the pupillary defect, you'd see decreased acuity. We would not want to do patching here. Why? Because patching would not get rid of the foreign body. Okay, you would actually push that foreign body up. Where is the foreign body usually? Is it on the eye? No, it's actually behind the eyelid. So it gets into the eye, you blink, and then it sticks to the eyelid, and then every time you blink, it scratches up and down and up and down and up and down. You got to get that off. So invert the eyelids, irrigate copiously. That is your answer. We do not want to patch it. So here is an algorithm for you. We're kind of just triage out the emergencies. If there's a perforation of the eye, obviously ophthalmology consult. You're gonna patch the eye and get ophtho down there ASAP. Corneal infiltrate, corneal ulcer, irregular pupil, we just talked about, and if the foreign body can't be removed. If the answer to all those questions is no, then you want to ask yourself, I mean, it's generally pretty apparent on the history. This guy clearly had a foreign body. However, if the patient says, yeah, this just came on this morning, and then you ask them, well, do you wear contacts? Yeah, and then you look at their nails and like, you need to trim your nails. They probably scratched their eye. Now, the big thing about contact lens abrasions is that we have to give antibiotics because Pseudomonas loves to grow in contact solution. And so we have to give anti-pseudomonal antibiotics. So we're talking about fluoroquinolones. We're talking about tobramycin. Just think of the drugs that you might give somebody with cystic fibrosis, right? Your anti-pseudomonal drugs. Ofloxacin is an ophthalmic preparation very commonly given for contact lens abrasions. Follow these patients up in 24 hours. You don't want to patch here because of the infection risk. Now, in this patient, we had a traumatic or foreign body abrasion. You want to irrigate to remove the foreign body. Again, look under the eyelid. Look at that palpebral conjunctiva. You expect to see a foreign body there, and that foreign body is, every time they blink, it's scraping up against their eye. That's why these are vertical lines of increased uptake, not horizontal, because the eyelids do not move horizontally, they move vertically. All right, topical antibiotics, you don't need to target Pseudomonas there, so you can just do erythromycin and then follow up as needed. So here's the Woods lamp, the fluorescein dye. You can see again here, it's a vertical excoriation. Basically what happens with this fluorescein is the uptake is wherever there's a corneal epithelial defect. All right. So here, again, this is a really obvious one here. You can see how it just went up and down, and it abraded the cornea. Now, it's important to remember two things. The cornea is very sensitive, and also it heals fairly quickly. It does heal fairly quickly. So this isn't something you're going to deal with for weeks on end. It should get better within several days. So here you can see the corneal abrasion, and you can also see the foreign body right here. See that little tiny thing? That's causing this big problem. All right. This is a corneal ulcer. This is totally different. Okay, but know the difference between a linear abrasion and a corneal ulcer. Okay, here's a corneal ulcer without fluorescein. You can see vessels growing into the ulcer. This is an open globe injury. So you can see here this almost almond shape to the pupil. And anytime the pupils are abnormally shaped, you have to think of actual full thickness trauma to the eye itself. Okay. So this is actually something called the Seidel test. So if you suspect a patient has an open globe injury, if you see that eccentric pupil, if there's decreased acuity, you can put fluorescein onto their eye, and then what would happen is the fluorescein would go in through that laceration and then come out, and it would drip down. And so that's a way that you can tell. Tonometry will also help you too. Okay, question 10. A 25-year-old man presents to the ED complaining of severe or sudden onset severe chest pain for the past hour. He describes the pain as crushing and points to his upper sternum. This has never happened before. Patient admits he uses cocaine on the weekends when he parties. He says, I know I need to quit, but I don't enjoy parties without my drugs. He has no significant past medical history and is on no medications. He doesn't smoke tobacco, he drinks alcohol on the weekends, and denies other recreational drug use. Vitals show a blood pressure 144/92, heart rate 110, respirations 19, temperature 98.6. Physical exam is unremarkable. EKG is as shown. I'm going to show you the EKG. We'll come back to the question. So here's your EKG. All right, we're going to go back. Chest x-ray is unremarkable. Oxygen, nitro, and aspirin and diazepam are administered. 25 minutes later, the chest pain remains and EKG is unchanged. Troponin 1 is undetectable. Which of the following is the best next step in the management of this patient? A, percutaneous coronary intervention. B, IV metoprolol. C, IV alteplase. D, pionifedipine. Or E, IV morphine. Okay, let's take a look one more time at that EKG, and then we'll go on to the answers. Okay, so here's your answer choices. And the answer is PCI. Okay, so what's going on with this guy? Obviously, he's coked out. 25-year-old men don't come in with heart attacks. And is he having a heart attack? You betcha. He's definitely having a heart attack. Lead 1, ST elevation. AVL, ST elevation. 4, 5, 6, all ST elevations. What kind of heart attack is this? It's a lateral MI. And particularly, it's a lateral STEMI. So this is an emergency. Now, remember that ST elevations don't always mean that you're having a heart attack. All right, if you have a transient ST elevation, that's myocardial ischemia. Okay, that happens. So, I mean, this guy could come in, he could have an EKG that looks like this, and then it could normalize. And it could normalize as you treat the cocaine intoxication. What do we do for cocaine intoxication? What's the drug of choice for a cocaine intoxication? A benzodiazepine. Ideally a strong one. Well, we gave a benzodiazepine. We also gave him standard treatment for a heart attack. That's another thing you've got to do. Anytime someone comes in, I got crushing chest pain, it's radiating down my arm, they squeeze their fist and they point to their chest. This is most likely a possible heart attack. Mona. Morphine, oxygen, nitroglycerin, aspirin. Now, we didn't give this guy morphine. Why? Because the benzodiazepine would probably be enough for the pain. Benzodiazepines decrease sympathetic outflow. They reduce your blood pressure. They reduce your heart rate. They reduce coronary vasoconstriction. They're really good for that. So you're actually getting at the underlying cause of the pain, which is primarily vasoconstriction. However, this guy is actually having an MI. And why would he have an MI? We're assuming his vessels are probably pretty clean. I mean, he's 25 years old. What does cocaine do in addition to causing vasoconstriction? It can trigger platelet activity. It can cause thrombus formation. And so that is why we held off a little bit. We didn't just see, okay, here's his EKG. He's having a STEMI. Get him to PCI now like we would for an older, if this was a 68-year-old who's on, who's got lipid problems and whatnot. Yeah, we would send him off to a PCI right away. But this younger patient, we're not going to do that because we're thinking this is probably cocaine-induced. However, because we gave medication to treat the cocaine intoxication and he is continuing to have ischemic changes, now we need to think he is actually having an actual thrombotic heart attack. And so now we send him to PCI. Okay? IV metoprolol, why not? You better darn well know you're not going to give metoprolol to a coked out patient. Repeat after me. I will not give a beta blocker to a patient who's coked out. Ever, whether you think they're having a heart attack or not. Yes, beta blockers lower your blood pressure. They calm you down. But remember, cocaine works by stimulating alpha and beta receptors. Well, if you block beta receptors with a beta blocker, You're going to have unopposed alpha adrenergic activity. What do alpha receptors do when they're stimulated? They constrict the vessels. Yeah, you would make this problem worse. Get rid of that. Remember that. No beta blockers in cocaine intoxication. IV alteplase, what's that? That's a fibrinolytic. Fibrinolytics are not preferred. If we can do PCI, we do it. PCI has to be done within 2 hours of first contact. So if you're talking about, you're in the middle of Alaska in the wilderness and, you can't get them off to PCI, then sure, alteplase, fibrinolytics, that would be fine. But if we can get them in for PCI, this has been going on for an hour, but he just got here, it's only been 25 minutes, then, we'll do the PCI. And on a test question, if they don't tell you that PCI is unavailable, assume it is. So that's out. Nifedipine, morphine, they're good for pain. They're not going to treat the underlying cause. Okay, so the answer is A. Cocaine use, here's your clinical features. As you know, sympathetic hyperactivity, the tachycardia, the hypertension, mydriasis. Coronary vasoconstriction, we saw that, can cause chest pain. Doesn't mean it's a heart attack because you are constricting those vessels. So that will cause some degree of poor perfusion. Doesn't mean it's a heart attack, but it can be, because remember, cocaine can promote thrombus formation. Seizures and psychomotor agitation may be seen as well. Complications include myocardial ischemia or infarction, as we saw in this patient. Aortic dissection due to very high blood pressure, intracranial hemorrhage, ditto, and diffuse alveolar hemorrhage. If they're snorting the cocaine, that can cause localized vasoconstriction in the lungs, which can lead to a hemorrhage. The treatment for the chest pain, start with benzodiazepines. Of course, oxygen, nitrates, and aspirin if they're coming in with chest pain. Nobody was ever hurt with oxygen. Nitrates are fairly safe. Nobody's ever hurt with aspirin except for little kids who should never get it. Ray's syndrome. So for blood pressure and anxiety, benzodiazepines, first drug we go to in any cocaine intoxication. Once again, repeat after me, I will never give beta blockers to a coked out patient. Okay, don't ever do that. It's always the wrong answer choice. And they're always going to want you to go for that too, because they're going to tell you, you got a patient with a blood pressure of 170 over 110. And ordinarily, we would give beta blockers. But we cannot do that in a patient where this is happening due to cocaine because of the physiology of these receptors, these alpha and beta adrenergic receptors. Again, fibrinolytics are not preferred. We go to PCI if there is no improvement in the chest pain and EKG. Okay, so we would hope in this guy, after we gave him the benzos, the oxygen, the nitrates, that we would see normalization on that EKG, but we did not. And so he is likely having a thrombotic MI, and he needs to go and get cathed right now. And this is from the American Heart Association. Basically what we just talked about, remember, if you believe it's cocaine associated, make sure to give aspirin and benzos. Aspirin for anyone who's coming in with chest pain. It is not going to hurt them. So just give aspirin. It can save a life. Benzos when you're thinking it's cocaine related, because remember, it's sympatholytic. It's going to reduce that sympathetic response, and so that can take care of the problem right there. You can give nitroglycerin. You can give morphine if you need to. Typically, you don't, though. So just think, remember, for a heart attack, morphine, oxygen, nitrates, and aspirin. But you typically do not need to give morphine when it's cocaine related. It's not going to necessarily hurt, but you don't need to. And then keep an eye on that EKG. If the EKG doesn't improve, you're probably dealing with STEMI and get PCI. So that is it. Just remember the big takeaway here: avoid beta blockers. Do not give beta blockers to a patient who is having symptoms of cocaine intoxication.